Welcome back to the Reinhartz Rundown. We are rocking through our COPD series, and today's video is about inhaled corticosteroids, or ICSs. Inhaled corticosteroids are widely used in practice for asthma, respiratory infections, and also for COPD. They are most useful in COPD only when we have a high blood eosinophil count, which tells us that a significant amount of inflammation is occurring. We'll make sure that we drop a link to our video on eosinophil count and COPD below. If that's helpful, go ahead and take a look. Inhaled corticosteroids have a variety of different side effects: hoarseness, oral candidiasis, cough, headache, dysphonia or difficulty speaking, and more. But one that doesn't get talked about enough is pneumonia. That is right. Inhaled corticosteroids can increase the risk of pneumonia and respiratory infections in your COPD patients. This has been proven in high-quality randomized controlled trials and has been shown that even low doses of ICSs can increase the risk of pneumonia. Here are some other factors that put COPD patients at higher risk: currently smoking, age greater than 55, history of either COPD exacerbations or pneumonia, body mass index or BMI of less than 25, and if they have a poor MMRC or a high amount of shortness of breath or breathlessness. Also, if they have severe airflow limitation or poor FEV1, they're at increased risk of pneumonia. So if the whole goal here is to prevent acute exacerbation and pneumonia, and one of the drug classes that we use can increase risk of exacerbation and pneumonia, we really have to be careful and consider thoughtfully which of our patients get an inhaled corticosteroid and who don't. Check out this table coming straight from the GOLD COPD guidelines. We probably do want to go ahead and add the inhaled corticosteroid if the patient has had at least 2 moderate COPD exacerbations in the last year or a hospitalization for a severe exacerbation. Also, we might want to add one if the blood eosinophil count is greater than 300, or if there is a history or recurrent concurrent diagnosis of asthma. Now, it starts to get a little bit tricky in this middle zone here. We enter our cautious zone, and we will consider use if a patient has had only 1 moderate exacerbation, or if that eosinophil count kind of falls mid-range between 100 and 300 cells per microliter. And finally, we really are against use of ICS in COPD patients who either have a repeated pneumonia event or frequent history of pneumonia diagnosis, or an eosinophil count of less than 100, or if they have a history of a mycobacterial infection like MAC or tuberculosis. All right, hopefully that review is helpful as you really consider the risks versus benefits of ICS and COPD. Hit that subscribe button. We'll be adding more videos on disease management and medication clinical pearls. That's the Reinhartz Rundown.